I'm delighted to welcome all of you. Bon appétit. And I hope you will enjoy spiritual food as much as your lunchbox. And we are now starting this session dedicated to renal denervation called Proof to Practice, Treating Hypertension with Ultrasound Renal Denervation, session sponsored by Recor Medical. And just, I would say, a quick glimpse into what we want to share during this session and what we want you to learn maybe is probably the latest evidence, the latest clinical evidence regarding ultrasound renal denervation is probably the major and the first objective. Second, how to select the patient, how to select the right candidate for the procedure. And finally, having the chance to be with people who are expert in the field, how to establish a center where you could offer renal denervation for your patients. So maybe without further delay, we start with the first session. So Professor Andrew Sharp, which will guide us through the latest clinical results in the field of ultrasound renal denervation. People will introduce themselves, but I will introduce our chat master. So if you are shy enough not to ask questions with the mic, you can send him some messages, and we will push these messages to the faculty and to the panel and answer to these questions. Andrew?
Okay, so I'm Andrew Sharp from University Hospital of Wales and Cardiff University. It's a pleasure to be talking about
Can you open the mic? Can you open the mic, please? Merci.
Great, thank you. Those are my conflicts of interest. Okay, so we're going to talk about the ultrasound device. So it's known as Paradise, and it's from Recor Medical, and this has been studied in the Radiance clinical research program. What it does is it involves an ultrasound energy emitter that's suspended inside a balloon, and water is circulated through that balloon and back out again in order to cool the balloon and keep the near field around the device free of excessive heat, so that the heat will be generated at a distance of 1 to 6 millimeters from the device. So this differs from some of the other devices in the field in that it goes deeper, but it spares the near field. And by sparing the near field, it protects the endothelium and the media and allows that higher energy to go deeper. What it also does differently from some of the other devices is that it delivers energy only at the moment, into the main vessel within the trials. So the main renal artery will receive ideally 3 sonications, as it's called, energy deliveries, starting at the distal main renal artery and then coming back to the mid and then proximally. And it's 7 seconds of energy delivery, meaning if you deliver 6 sonications in total, 3 to the left, 3 to the right, you end up with 42 seconds of energy delivery, and about half that time induces discomfort. So you're looking at about 25 seconds of discomfort during the procedure, which means that you have quite limited pain and sedation requirements. Here are the 3 sham-controlled trials that have been successfully delivered and published. We have Radiance Solo and Radiance 2, which are similar designs. They're designed to be off medication. So we took patients in with mild to moderate hypertension. We removed medicines from them, which is the current recommended way to approve a new drug in hypertension. It's the same mechanism. And then what you do is you go out to a relatively short endpoint, 8 to 12 weeks. This is the FDA recommended design. And then you see whether a placebo-controlled trial shows efficacy at that period. So that's what we did here. We had a sham arm and we had a treatment arm. And then at 2 months, we demonstrate whether or not there's significant blood pressure reduction from the treatment versus the sham control arm. Then we have the on-meds trial, which is Radiance Trio. So this is a true resistant hypertension cohort meeting the ESH and AHA definitions of 3 or more antihypertensive drugs at screening, including a diuretic, and then we put them onto a combination pill, which was olmesartan, amlodipine, and hydrochlorothiazide, and it varied a little around the world according to the formula. But the point was it was a triple pill, including a diuretic. So we were studying a true resistant hypertension group. They had to have elevated blood pressure despite a run-in period on that single pill. And that standardization is really a very high-quality aspect of the Radiance Trio study. And then we took patients who had residual hypertension and we randomized them. And you can see the numbers of patients there. Primary endpoint is at 2 months. If you wait too long, then you get behavioral change. So patients start getting extra pills added, or they start becoming more non-adherent. And that's why the FDA recommends this shorter endpoint in these studies. And also, if you're off med, you don't want to leave them off med too long. So here's the headline, really. We have 3 very similar looking studies, which emphasizes the predictability of ultrasound renal denervation, in that we have the solo off med showing a fall of about 8.5 millimeters of mercury in daytime ambulatory systolic pressure. This isn't office, this is ambulatory pressure. So as you know, ambulatory pressure produces a slightly smaller effect for any given treatment compared to office. And so 8.5 in an ambulatory reduction is a very strong result. And the sham result of 2, we managed to limit that variability in the sham arm that we saw in some of the older renal denervation trials, where we're getting these crazy blood pressure falls in sham arms of 10, 15 millimeters of mercury. That's occurring because of behavioral change or drugs being added or taken away. You don't get that much from a placebo. And again, we've managed to control the sham arms nicely in all 3 studies, showing a very minimal effect. And in fact, when you drill down into the data, many of those were patients who started drugs again or had drug escalations because their blood pressure went too high for the study. So what do you get if you get denervation? 8, 8, 8. Remarkably similar from 3 different studies. We then put the treatments together in a pooled analysis that we recently published in JAMA Cardiology. And what you see from 293 patients randomized to ultrasound denervation, they're a pretty average group. You know, these are not exotic patients. It's 54 years old, majority men, mostly white, mostly overweight, as many of our hypertension patients are, with preserved renal function and a smattering of risk factors like diabetes and previous hospitalizations. Their starting blood pressures on office about 154 over 100. So moderate hypertension. Remember, some of these were off meds, 2/3 or more than 2/3 were off meds, some were on med. This is what their blood pressures were going into the study following all the standardization procedures. And you can see the ambulatory pressure is proving this isn't a white coat cohort. This is a cohort of genuine, moderate, maybe mild to moderate hypertension. And when you put them all together, surprise, surprise, given how similar the 3 studies were, what you see for the 3 different measures we used in the studies, ambulatory pressure shows a significant reduction for the procedure over sham. Home blood pressure shows an even bigger one because we're starting to limit some of that variability in the sham arm, and because we get many more measurements from the home blood pressure monitoring. And again, office again showing a significant blood pressure reduction. 10 points of office blood pressure reduction. You'd expect a 1/4 reduction in stroke and heart failure and a 1/5 reduction in MACE. So these are valuable blood pressure reductions. The so-called always-on effect. So you get it 24 hours a day. So there's no short-acting antihypertensive agents that disappear at night. You're getting, in many ways, we've seen this throughout multiple studies, a bigger effect at night from renal denervation procedures. So that may be real, that may not be, because we're not talking about ambulatory profiles in 10,000 patients. But you know, we're seeing this signal throughout that we're getting more of an effect at nighttime. And those of you who keep up with ambulatory blood pressure monitoring studies will know that nighttime blood pressure is the strongest predictor of events. And that might be to do with that morning surge. Do you see the blood pressure coming up at the end of the profile? That's a peak time for cardiovascular events, particularly stroke and heart failure, 2 of the diseases that are most often driven by hypertension. So if we can blunt that more effectively with a procedure, then that's valuable. It seems to be consistent throughout cohorts. We didn't see any group that fell out. You know, 1 or 2 of the groups are smaller, and so the confidence intervals are wider, but the point estimates look pretty consistent. So how do you predict success, or how do you describe success from one of these procedures? Well, there's 2 ways to think about it. The first way is, do you get a large fall in blood pressure? But we know from 12, 13 years of the field, the thing that strongly predicts the largest fall in blood pressure is a high starting blood pressure. So that's a mixture of things. It's regression to the mean. It's perhaps a more severe hypertensive state. It perhaps indicates a more active sympathetic nervous system. But whatever it is, we're seeing it across almost every data set that there is in renal denervation. Start with a high blood pressure, you get a bigger fall. But there is another way to think about it, which is, do you achieve control? Now, if I start with a blood pressure of 180 over 100 and I have a renal denervation procedure, I am not expecting to get to control because it's too far a drop. But I might get a big fall in blood pressure because I start so high. Similarly, if I start with mild to moderate hypertension, the sort of thing where my general practitioner will give me a time to try lifestyle and then maybe 1 drug to try and control my blood pressure, do I get to control with renal denervation? And what we saw is with the left-hand bars, do you get a fall on ambulatory blood pressure, the more powerful measure, of more than 5 and or get to control? And about 2/3 of patients exhibited a response to that with a denervation. We saw some of that in the sham arm as well, because of regression to the mean phenomenon. And then the perhaps more impressive, greater or equal to 10 millimeter blood pressure fall on ambulatory monitoring and or getting to control, occurring in about half of patients. So I would call that a very good response from a renal denervation procedure. You're either getting 10 or more points off your ambulatory or you're getting to control. Both of those are desirable things from any hypertension treatment. And of course, you might see something similar with amlodipine 10 milligrams, you know, if you were putting it head to head with that. And we showed that in this tertile analysis, if you have mild hypertension on ambulatory, remember this is ambulatory where in the UK, the target is 135, and in Europe and the US now, it's 125. What are the chances of you getting to control if your blood pressure is less than 145? With renal denervation, about 42%, and then it drops to about 1 in 10 if you've got more severe hypertension. But then if you look at the proportion, the change in blood pressure in those patients, you get a much bigger fall in the group. So it's a different way of describing what I showed you on the previous slide. Severe hypertension gets a big fall, but because you're so far away from control, you might need other treatments. If you're near control or not far off it, and denervation can get you there about half the time, but you get a smaller absolute reduction because there's a floor in blood pressure. There's other ways that the body prevents the blood pressure from going too low, as we heard in the other room a minute ago. It's a very safe procedure. It's a remarkably safe procedure. If you'd have told me 10 years ago that a femoral access arterial procedure, which is 7 French with this device, would produce so few complications, I'd have bitten your hand off. So remarkably good, and operators really are a lot better at femoral access these days, particularly in these studies. And I think it's the TAVR experience. We've learned from the TAVR experience. Here we see the longer term data. I would just caution that on the left, the solo data is an additional 1 point something drugs on top of denervation from 6 months onwards. But what we see is a consistent drug burden, and we see consistency of effect out to 36 months. So we're not seeing any degradation of blood pressure as time goes on the same pill burden. TRIO, again, we're seeing maintenance of effect. And ACHIEVE, which was an earlier study, again showing maintenance of effect. And we're going to have some more data to come demonstrating durability in the near future. So this is part of a fairly large program going back not that far. I mean, it's, you know, if you think about this field, we're looking at a rebirth in 2017 after the disappointment of HTN-3 with new technologies, new trial designs, and we're seeing this as part of a program that is now being referenced in many consensus statements around the world, supporting the use of this as part of a mixed modal approach to hypertension, lifestyle, drugs, and now devices. This is an important consensus statement. You'll hear more about this afternoon. This is the first time a major international organization that's led by pharmacologists and cardiologists who don't do interventions, the ESC Council on Hypertension, and interventionists have come together and agreed that this has a role in treating high blood pressure, and they've suggested that it's patients with resistant hypertension treated with 3 or more drugs, confirmed not to be white coat, with relatively preserved renal function. If you're in that scenario, of which probably 10 to 15% of the hypertensive population are, then it is reasonable to consider renal denervation in that scenario. There's also this other difficult group who can't take pills. We know there are many of those, and they should be considered, but that has to be a shared decision-making process. You've got to do your best for these patients to make sure they've had the right drugs, the right opportunities for conventional management before you start considering devices in those, according to this consensus statement. And also, we need to think about the patient. If you've had someone who's had 3 heart attacks and a TIA, they need blood pressure lowering more than someone who's 35 years old with a new diagnosis of hypertension. This is the extensive program that RECOR have put in place. The GPS registry is now underway, and that's going to give us that large-scale real-world safety data. But there's various other ones around, including some focus trials on indications like chronic kidney disease, arrhythmia, and heart failure that are going to be very interesting indeed. The GPS registry is up and running, and in fact, my centre received approval to start yesterday, which I'm very pleased about. So 3,000 patients with 5-year follow-up, and it's going to give us some good real-world data. So in conclusion, the response to ultrasound renal denervation has now been demonstrated across different severities of hypertension, mild, moderate to severe. The response seems to be related to starting blood pressure. We've shown that it lowers blood pressure significantly in the presence or absence of medications, and the safety data are surprisingly good, really. I mean, any device to have such a low complication rate when delivered via the femoral artery is remarkable. We need more real-world data. We need bigger data. It's coming. It's enrolling. And so with a bit of luck, this is going to be a part of mainstream hypertension management in the coming years. We now have recommendations to include it for those patients who are difficult to control. So this device is becoming accessible now. Thanks very much.
Thank you very much, Andy, for this nice update. I think we have now a couple of minutes for audience interaction online or on site. Maybe my first take would be to you, Andy, just to start the discussion. So you think we have reached now the required level of evidence to start using the therapy in clinical practice?
Well, this field now has 6 positive sham-controlled trials. I do a lot of cardiovascular device work, and none of the areas that I do cardiovascular device work in have 6 positive sham-controlled trials. Yeah, there are a couple that are negative, but on-med studies are incredibly difficult to do. In TRIO, we have an on-med resistant hypertension cohort with positive sham-controlled data. The hardest study possibly to do in medicine. I mean, I've done a lot of studies over the years, and it was incredibly hard to do and deliver. So I think, what more do we need? I think GPS is valuable, large-scale, real-world experience. But if you look at the Medtronic Global Registry, that's shown even better results than the sham-controlled data because it's more severe patients. So I think we'll probably see that GPS shows even better results in the real world, and I think that's encouraging.
Any comment, questions from the panel or from the audience? Yes, please. Can you go to the microphone, please, and just introduce yourself, please?
Hi, Dr. Mohammed from Iraq. I just want to ask about this procedure. Is it considered for resistant only? Is it a step-up treatment, or what is the strongest indication to use it? Thank you.
Yeah, so the consensus statement has said that the best group are resistant hypertension. So they're on 3 or more medicines, including a diuretic, and they have uncontrolled blood pressure as the best group. The procedure itself is very straightforward. You can do it as a day case procedure. You do it under sedation. They can be up and around in a few hours and home in 4 or 5 hours. So it can be an outpatient procedure that can be delivered very efficiently.
Is it efficacious for step-down treatment or the just control?
Is your question, will it allow you to take drugs away? Is that the question? Yeah. I think it's unlikely because we're only delivering it in patients who've got more severe hypertension. I mean, we're not going to really focus on patients with a blood pressure of 142 over 92, in which case, if we did denervation, we might be able to reduce one of their pills. In the real world, the pressure is to what do we do about these patients with a blood pressure of 160, 170, 180? And we're going to have an expectation. We're going to drop 10 to 15 points from these studies and from others, in which case we're getting uncontrolled to control on their current pill burden. So I think I do not counsel patients that we're going to take away all their medicines. I think that would be wrong. What we're looking at is an effect size of 1 to 2 pills worth, which in the real world is 10 to 15 points of blood pressure. And I think that's good. That we'd expect a significant endpoint reduction with that.
Thank you. Any comment, Felix, you wanted to?
Yeah, probably that something that we're not emphasizing enough, or at least I don't emphasize that enough, is the proportionally larger fall in nighttime blood pressure that we are consistently observing in all studies. Would you mind commenting on that and what it probably means in terms of long-term follow-up of these patients with respect to reductions of cardiovascular events?
Yeah, well, as you know from the PAMELA study where they looked at ambulatory blood pressure monitoring and then subsequent outcomes, nighttime pressure was a stronger predictor of outcome than 24-hour blood pressure, daytime ambulatory pressure, or office pressure. I always think of hypertension as like the miles on the clock of a car, and you're asleep for 1/3 of the day. And if your blood pressure isn't falling 15,
Never
20...
on call.
Yeah. Unfortunately, not me. But if you're running your car hot at night in the garage, then I think that's probably a very bad prognostic factor. And the fact that it seems to be more demonstrable and more powerful at night, that could be an artifact because daytime is full of drug confounding and nighttime is a cleaner period where we're not starting and stopping drugs as much. But if it is real, then that early morning surge that is associated with a higher event rate of blood pressure from the cortisol spike early in the morning, if we are blunting that more efficaciously, then it may have a bigger yield on outcomes.
Sebastian, we have a question from the chat. I give you the mic.
Yeah, Andrew, we have two questions for you. The first is, you mentioned the safety from puncturing the groin. How's your experience with a radial access?
So the device is not yet long enough for routine radial access. So the catheter shaft is too short. So the iterations are now coming, but I think we're more at the prototype stage. So we're probably looking at a couple of years before we have commercially available radial devices, but they will be investigated in the next 1 to 2 years. I think the real attraction of this is that you wouldn't even need beds, you wouldn't need a ward, you could just do trolley recovery or chair recovery with radial access. And it's entirely feasible. There have been cases done. I think Justin in thorax has done some. But because the device is so short, you need very short patients. So we can't just restrict it to 4'11" hypertensives. That wouldn't work. So the new device is coming, and it will be radial compliant, and I think it will work nicely.
Perfect. And the second question is regarding the anesthesia protocol.
Yeah.
So do you perform the procedure with general anesthesia or just deep sedation?
No, I've never used general anesthetic, so only deep sedation. So with this procedure, it's 42 seconds of energy delivery if you do 3 to each artery as intended. And as the energy warms up, you tend to get pain from about 3 or 4 seconds onwards, and then it stops at 7 seconds. So you do want to have your patient well pain controlled and sedated. You know, it's more sedation than you would use for an angiogram or for, you know, a very simple procedure like a pacemaker, but it's manageable. And most patients don't come to me afterwards and say, I wish I hadn't had that. I mean, there are procedures where they do say that sometimes, you know, 3-hour CTOs and all that, but they tend not to come afterwards from denervation procedures and say, God, that was awful. Pardon the blasphemy.
That's the question.
Please.
If you use the Dormicom, they don't remember.
They don't
Yes,
remember.
exactly. Midazolam, yeah, midazolam is a key part of the procedural management.
Okay, are there any other questions? So then we might move to the next presentation. I invite Professor Felix Marfut from Homburg-Saarland to share with us some thoughts about the latest statements, guidelines regarding the treatment strategy. Felix, thank you.
I thought I uploaded the wrong topic, but it's treatment, right? Treatment strategies. Yeah. I thought you wanted me to
Very long
discuss guidelines. But anyway, that would be a nice topic too. So I was invited actually to talk and guide you through the procedure, how it's being done. It's pretty straightforward, which you will see in a second. I've brought some videos from a case that we recorded in our institution in Homburg-Saar in Germany. And I'll start by showing my potential conflicts of interest. And then I'll show that summary picture just by, you know, getting you a feeling of what is required for this procedure. So you need a catheter that comes in different sizes. It's a balloon-based system. You have seen that being introduced by Andrew already. It's running over a wire. It comes with an atraumatic tip, and it has also a balloon which is non-compliant. And the whole idea here is that you circulate cold fluid during energy delivery, and that should then protect the endothelium. There's a generator with very few buttons, so it's quite easy to handle that one. And you can see on the right-hand side that you also need some catheters to engage the renal arteries. We can discuss that. In most cases, I guess an RDC is the best catheter to engage the renal artery ostium and to deliver that device. So what we're doing here is we are creating a donut-shaped circumferential quadrantic treatment with this procedure as shown here. So red indeed indicates the heat that is delivered to the perivascular space and the renal nerves that are located there in a depth of 1 to 6 millimeters, which should cover most of the nerves located and traveling along the renal arteries are targeted. And we have a target width of around about 5 millimeters with this device. Again, the concept, and this is an important feature of the whole system, is to cool the endothelium, to protect the endothelium while delivering the energy. It's getting quite hot, which you can try when you unpack the device. You can get a feeling how hot it gets on your fingertip when you emit ultrasound. And again, this whole cooling feature here is a concept that should prevent the progression of renal artery disease or cause renal artery disease. That's the idea here. And we haven't seen any of these occurring in the randomized sham-controlled studies. This is an angio, hold on, this is an angio, a thermal gel model, a video showing what we're doing here. So you have seen the first ultrasound sonication on the left, and now we're emitting energy. You will see the visualization change in a second. When you look at it from anterior to posterior, which is shown here in a coaxial view, you can see now in thermal gel turning opaque where it is heated, and again the endothelium being protected, the 1 millimeter space, which is indicated here blue, but you can also see that it remains transparent, and this is an indicator that no energy, no heat is delivered to that circumferential space around the renal artery, indeed within 1 millimeter of the energy delivery. Treatment strategy is pretty straightforward. There is no need to embark into the segmental renal arteries, so we stay proximal to the first bifurcation as shown here. We have a space between each of the sonications of more than 5 millimeters as shown here. And in the clinical trials, we have done 3 sonications per main renal artery, 2 to 3 depending on the length, but at least 2 was the requirement for the sham-controlled studies. Of course, it's not always as simple, and you will see that in a second, as simple as on these drawings. The renal artery anatomy can be quite variable across individuals, and then you have to change the treatment strategy, the treatment plan. So first identify what is the main renal artery, here shown on the left. The larger renal artery is the main. You would stick to that main renal artery by emitting 2 times ultrasound just prior to the bifurcation, and then there is this accessory or polar artery that supplies a significant proportion, and we define significant proportion of the kidney parenchyma by more than 20% of the kidney shadow that is supplied by that renal artery. In case that is observed, then you would treat the polar or accessory renal artery as shown here by 1 sonication, and you would avoid that these treatment zones are overlapping in this patient. On the right-hand side, a different example. Again, identify the main renal artery. We have a short main stem here. We would probably too short to get an ablation performed and a sonication performed prior to the bifurcation. Then you change your treatment strategy. You stick to the area proximal to the bifurcation and the subsegmental renal arteries. You do 2 emissions in the so-called main, then you embark into the branch that supplies the superior part of the kidney and emit 1-time ultrasound in that renal artery too. We treat everything that is larger than 3 millimeters. This is an example out of our institution, a patient that was referred for treatment of resistant hypertension. You can see here a pretty long main renal artery with a bifurcation that is long enough for treatment too, but actually not long enough for 2 emissions, which is why we also treated, as you will see in a second, the so-called main post offtake of this smaller artery that is supplying the inferior pole of the artery. So what we did here is we wired the renal artery, the main renal artery. We tracked the catheter down here. We inflate it, which is done here by Sebastian actually, who's sitting on the panel here. You can see here the generator indicating that the balloon is inflated. You check that you have occluded the renal artery completely, that there is no contrast dye bypassing the inflated balloon to ensure that you have proper cooling. You emit 7 seconds energy, balloon is deflated, that's it. So I talked actually longer than the video is here in that case. So I'll be quicker here for the main renal artery. So we did 1 treatment proximal to the bifurcation into that polar, into that artery that supplies the inferior part of the kidney. You can see the wire here being tracked in the main renal artery. So you inflate, you check that the artery is occluded completely. then ultrasound is emitted for 7 seconds and you remove the catheter. And again, we have done in that case 2 treatments in that main renal artery and 1 prior to the bifurcation as shown here. What you have to keep in mind though is when you have different artery sizes, you have to exchange the catheter. It comes in various sizes, and here we use the smaller balloon distal to the bifurcation, and in the main stem a larger balloon. What you can see very frequently, and this is irrespective of whether you use ultrasound or RF or alcohol, you see spasm occurring, or notching as we call it, which sounds a little nicer. And this is the case here too. You see where we emitted energy here and a little here, I guess. These are the areas where there is a kind of a spasm occurring, which disappears typically within minutes to hours post-procedure. And the very first cases that we did back in 2010-11, we did re-angios, and Mariesta is sitting in the room. We were all doing re-angios to ensure, because we have seen quite some spasm in these renal artery, particularly in younger women. We have done re-angios to confirm that they are disappearing, and they are, so there is no real threat that is associated with the occurrence of these notches that typically are observed following energy emission. So in conclusion, this system is designed to deliver a circumferential, a donut-shaped 360-degree ultrasound energy to the periadventitial space where the renal nerves are located. It protects the arterial wall, the endothelium. Pre- and post-sonication, there is a cooling algorithm installed that again should protect the endothelium and should not induce any harm to the vessel. There are short 7 seconds energy delivery, which increases patient comfort during the procedure. And as Dr. Sharp was mentioning already, it's pretty straightforward also in terms of what you have to tell the patient, because the 7 seconds are, they're turning quite quickly for most of the patients. And as soon as they recognize pain, it's already done. And it requires only 2 to 3 sonications per main renal artery when you use an ultrasound-based system. With that, I'd like to thank you very much for listening, and I'm looking forward to your questions now. Thank you.
If anyone has questions, come up to the microphone. We welcome them. Yeah, please do. Yeah. Tell us who you are and ask your question.
Eric Holy from Zurich. Thank you very much for this beautiful overview. I have a general question. Do you have any absolute contraindications for this method? And the second question would be, do you have any experience in end-stage renal disease patients with uncontrolled hypertension using this method?
I was about to say absolute contraindications for renal denervation, end-stage renal disease probably, but then you brought it up. So I would be a little cautious in end-stage renal disease. Scientifically, a super interesting target. And by the way, you are sitting next to a nephrologist here in the room who's also interested in exactly investigating this. We know that the failing kidneys have a significant outflow of sympathetic activity, so the idea of denervating them is plausible. But technically, it can be challenging. The arteries are getting atrophic. The lower the eGFR is, the smaller are the arteries. That then can interfere with cooling during the energy delivery. So it's not as simple as one would might, and there is a lack of data, right? If you want to do end-stage kidney disease, I would only do it in a trial. But other than that, you know, in the consensus document that was referred to already, eGFR should be above 40. Transplanted kidneys is another contraindication. We don't know whether that would make sense. Secondary causes of hypertension. We don't have any experience because they were excluded. I mean, really not obstructive sleep apnea. I mean, really secondary causes of hypertension, such as hyperaldo or pheochromocytoma. These are actually no patients where I would consider renal denervation.
Come to the microphone.
Excuse me, I ask too much.
No, please.
Thank you. The possible complication, expected complication. Also, the success rate and failure rate, which is very important. We have to ask about it.
Absolutely.
So, and my another question, renal artery stenosis, if in the previous intervention did for him,
Yeah.
have role to do this procedure or not?
Yep.
Thank you.
So let's start with your third question, which was renal artery stenting. We have published a paper back in 2014 where we looked into stented renal arteries in pigs and confirmed that it is safe to deliver energy to stented renal arteries as long as you sparse the stented segment. So don't touch the stented segment, distal to the stented segment. You can do that safely. 5 millimeters was the range, actually. And while doing so, we observed that the more distal we go, the higher was the NAPI concentration. That was actually the first observation, triggering then this whole concept with RF technologies to go distal and to go into the branches. I didn't forget, yeah. Success rate, I'm always telling my patients it's 75%, so 3 out of 4 patients have a blood pressure lowering following denervation. 1 out of 4 has no significant fall in blood pressure. I cannot tell you individually whether that patient responds or not, but I can tell the patient that through that procedure, blood pressure is not increasing. You have a chance, 75%, of a reduction in blood pressure and a very, very low likelihood of an increase in blood pressure due to the procedure. The expected changes in blood pressure are around about 15 to 20 millimeters of mercury in office systolic in those patients that we treat. 3 drugs or more, blood pressure of 150 to 160. There you see changes of around about 15 to 20 millimeters of mercury for office systolic and around about 10 to 12 for ambulatory blood pressure. And complications, potentially dissections, potentially perforations. For me personally, the most realistic complication that may occur is a distal perforation of the wire, which is why you should never use hydrophilic wires in renal arteries. Guys working with us know that I'm telling that all the time. Don't use hydrophilic wires in renal artery interventions because they are quite slippery. They can go distal when you maneuver with the catheter, and you can cause distal perforations and bleedings then. And this is just unnecessary, and you can avoid that by not using hydrophilic wires.
Felix, we've got 2 questions online. Sebastian?
Yeah, Felix, we have questions regarding the sizing of the adequate balloon.
Yeah.
So what's your strategy? And the second question is regarding the one-size-fits-all strategy.
Yeah.
So what's coming up?
So sizing is what we do using a QVA. We do an analysis, quantitative vascular analysis, to measure the diameter, and we agree upon with a representative of the company who comes with all the balloons, which you typically don't have on the shelf. You agree on the treatment strategy, then you measure where you want to treat, and you pick the balloon, which you confirm then as soon as you have introduced it into the renal artery that it's really large enough to occlude the renal artery, and then you proceed with the treatment. Of course, further down the road, and this is what RECOR is working on, actually getting 1 balloon size for all renal arteries, that would even further simplify the procedure because then you do not need to exchange. But there is no cost associated for the center. At least this is something people have in mind too. So if you exchange balloons, you're only charged per procedure. You're not charged per catheter or balloon that you use for the patient.
Sophie, you have a question?
Yeah, Felix, you just said that you are telling the patients that 3 out of 4 are responders, so to say. What do you tell them about the timing of their response?
Yeah. So first, response is difficult to define. But patients care most is blood pressure lowering. And I say typically we should see something at 12-month follow-up. If we haven't seen at 12-month follow-up a change in blood pressure, then you would probably be called a non-responder.
Okay, thanks very much,
Thank
Felix.
you.
Thank you. Okay, so patients are variable. So we're going to hear from Sophie Browse now, Professor Browse, about some cases that she's been involved with, and we can learn from that experience. Thank you, Sophie.
Good afternoon, everyone. I'm Sophie Brouwers from the Cardiovascular Center in Aalst in Belgium, and I teach at the university in Brussels. I brought a couple of cases, all from this year, seen very recently back. We decided on having an interactive discussion, so I will present the initial part of the case, and then we'll discuss what everybody would like to do, and I'll present how it ended up for my patients. So I have a 63-year-old male patient with obviously arterial hypertension in his medical history, dyslipidemia, psoriasis, atrial fibrillation, currently under rate control. Even the electrophysiologist left it there. In 2018, he had a coronary angiography with diffuse coronary atherosclerosis, but no focal stenosis. And he's treated with CPAP because of severe obstructive sleep apnea. He stopped smoking in 2016. There's nothing special in the family history. He has no diabetes, arterial hypertension, dyslipidemia, as I said, and he is obese. This is the medication schedule. He's under aspirin, he's under hydrochlorothiazide and bisoprolol. He's taking Pantomet, he's taking rosuvastatin and Sevicaris, olmesartan and amlodipine once daily. And he has no special symptoms. He just has an uncontrolled hypertension for as long as he can remember, and is now referred to our hypertension clinic because the GP doesn't know what to do anymore, and the patient absolutely is in the meantime convinced that his blood pressure needs to be controlled better. So on clinical examination, I measure a BMI of 34. I have blood pressures repeated left and right that stay around 180, 177 over 115 with a heart rate of 89. And further, besides the obesity, there's nothing special to report from the clinical examination. He comes into the hypertension clinic with an ABPM from outside the hospital with only the values written on, and the mean 24-hour ABPM measurement tells me that on 24 hours the mean is 151 over 92 millimeters of mercury. And also the GP asked already for an echography of the renal arteries where there were no special problems identified. He comes also in with a lab test with a normal renal function with hemoglobin A1C of 5.5, with a LDL cholesterol of 76 milligrams per deciliter, telling me that he's most likely taking that medication, normal thyroid and liver tests, and a normal renin-aldosterone ratio and a normal cortisol. So, the next step is that we discuss already lifestyle, and he tells me that after he had a discussion with the GP, he increased his physical activity. We all know that increase can come from very little physical activity. So I asked him what he's doing, and he's taking the stairs now instead of the elevator to the first floor on his job. That's increased physical activity. So always need to specify. And then he's reducing his salt consumption. He was basically using salt on everything all the time, and he's trying to reduce that. He's not the one cooking at home, usually in this age range. And he asked his wife also to reduce the salt consumption in the kitchen. He's trying to get to a healthy lifestyle, and he's aiming for a normal weight, but he's far behind on that. So I think the next question is, what should we do? What should we say? What would you do?
Sophie, can I just ask you to clarify one thing? Do you mind going back to the meds? Could you tell us what the generics are?
Yeah, that's what I said. Sevicaris, olmesartan. So he's taking a sartan, a calcium antagonist, a diuretic, a beta blocker as medication.
Thank you. Thank you.
We can add aldactone, spironolactone.
Okay.
They are positive, but you know, the diagnosis of pheochromocytoma is not easy at that. We can execute it by just 1 year ago, in Athens, they considered 8% of people who even undiagnosed as a Crohn's disease. So at the beginning, I add aldactone and C.
Okay. Concerning the pheochromocytoma, if we have no anamnestical hints for a pheochromocytoma, we're not screening regularly anymore. Yeah, Crohn's disease for hyperaldosteronism, we do. Other suggestions?
Yes, please.
How about his drug adherence?
Excuse me?
He takes the drug every day, every time.
Drug adherence.
Compliance. So as discussed, I have another case later. As discussed, seen the history, seen his motivation, so to say, I considered, and I know we are very bad in deciding whether they are taking it or not. The thing is, we usually do an observed ABPM blood pressure measurement, but he came already in with one, so I was not really pushing forward on doing the ABPM measurement again.
But the LDL looks like he's taking the statin.
That's what I said, yeah.
And the HbA1c looks
Yeah.
like is adherent
Yeah.
to diabetes treatment.
So we presume, and I have to say, in Belgium we are not able of doing it differently, of measuring it in blood or in urine.
Why didn't you anticoagulate the patient?
He was anticoagulated, basically because the atrial fibrillation, he had a chest FASC of only 1, and then they decided on giving Azaflow because of the higher risk. He passed by the electrophysiologists already.
And what about increasing the dosage of beta blocker and thiazide?
Yeah, he had problems with tolerating the bisoprolol in a higher dose because he felt really, down and
fatigue.
Fatigué. So that was already tried, and honestly, I do not expect when I double the dose to have such a big result.
So hands up for denervation for this patient. Hands up for who wouldn't. Go on, you're allowed to. Everyone's shy.
Who would try something else and wait much longer for renal denervation? I guess. Yeah. No one. We're on an interventional conference.
You have a selection bias, I think.
I'll ask the same question on a nephrology conference next time. So. Yeah, that I agree. So basically, we discussed the lifestyle measurements. I sent him to the physiotherapist and to the dietitian because we do it often in the cardiac rehabilitation center where I also work to get him moving, because in the end lifestyle is the basis of everything. So for all the other risk factors and for hypertension, this is very important. So that was step 1, and I added spironolactone 25 milligrams once per day to start off. This is the ABPM that I performed then afterwards, and then we had so this is under spironolactone. We have an observed pill intake. I think this is very important. And so the patient did take the medication before getting this ABPM measurement. And here we see that on 24 hours, we have 142/88 millimeters of mercury of average blood pressure. And so the patient stays over 24 hours by day and by night hypertensive. And so basically, then we referred him for renal denervation.
You slid him into the lab that day.
Yeah. Yeah. At the end, you took out the slide. Yeah, it's true. I have the slide with the. I'm quickly gonna move forward because this is the result of the patient, because I think it's a really impressive result. This is the patient I saw back, and I just wanted to highlight this is only 6 weeks after the renal denervation. Also one of the reasons I asked Felix, because I have the impression in the hypertension clinic there is a huge range of patients only after 6 months to 1 year only responding and getting their blood pressure down. And so this patient basically came back within 24 hours, a completely normalized blood pressure after renal denervation. So good. Oops. And then case 2. Here we have a woman. She's 68 years old, had an appendectomy, inguinal hernia, also hypertensive, obviously. She had malarial edema under amlodipine treatment. She had a PCI in 2005, and she's also under CPAP treatment for obstructive sleep apnea. She never smoked. She has a positive family history for hypertension. She does not have diabetes. She's obese, but she tries to move 4 or 5 times a week. And she goes on holiday to the mountains, and she really tries to be active. She's taking also Azaflow after the PCI, Felix. She's taking Coversil, so perindopril, 10 milligrams, rosuvastatin, 10 milligrams, Emcoritic, which is a combination also of hydrochlorothiazide and bisoprolol. She's taking also ezetimibe, she's taking moxonidine, and she's taking a spironolactone. Also in the anamnesis, we have a long-standing history of hypertension. She says as long as she can remember in her adult life, she never had basically a normal blood pressure, and she's tired. And I think this is very typical because we often say that hypertension is a silent killer, but we have to be more, we have to pay more attention to women because usually women tend to be tired, have headaches, migraine kind of headaches, and they are actually, hypertension is not so silently in women, so classical case. She's only 1 meter 68 for a weight of 94, which brings me to a BMI of 30.5. And also here, left and right blood pressure measurements. As you can see, some stress reaction on the first measurement, but then she goes down and stays down to only 157/101, so clearly hypertensive, with a heart rate of 61, which makes me think that she's taking the combination therapy. Further, there's a normal examination. She came, I think 10 years ago, she went to another hospital where they looked into every other cause of secondary hypertension. I'm not going to list it here, but that came out perfectly fine. And she comes into the office after having an echocardiography with a normal ejection fraction, but a left ventricular hypertrophy. The lab results that she also brings along to the hypertension clinic is again a normal kidney function, a hemoglobin A1C close to 6 already, LDL cholesterol 71 milligrams per deciliter, which makes me also think she's only on the rosuvastatin 10 milligrams and ezetimibe. She's taking the medication, although this is not perfectly controlled, but outside the scope of this case presentation. And she has normal thyroid and liver tests. As I said, she's trying to move 4 to 5 hours a week. She's trying to bike everywhere, but on her electrical bike, not on the eco modus. She reduced her salt consumption already a while ago. She's trying to eat healthy, but she has to admit that whenever there's sweets in the house, she finishes them. And she's also aiming for a normal weight wherever in the last 10 to 20 years. So what do we do? I go back to the medication.
Anybody like to comment?
Send her home and say it's hopeless.
Yeah. Yep. Costas?
Yeah, and here she's not on a calcium antagonist because she had malleolar edema on amlodipine, and she's actually absolutely, she has an aversion for the medication. She doesn't even want to try lenacardipine. So
just repeat that for the people who are watching on camera. It's more thiazide was recommended amongst other things. Yeah.
So of course we have here again the dietitian. She was already going to a dietitian. She's been there on and off for the past 10 years. We try to increase daily activity, emphasizing what else she could do. And then we switched the dose. So we switched to carvedilol to have a vasodilating beta blocker. We switched to Coversil plus, so perindopril with indapamide in the full dose. I convinced her to take
Vous pouvez fermer la porte, s'il vous plaît,
canidipine.
mademoiselle.
20 milligrams. She was already taking spironolactone, and I made a combination therapy of Sufezen, and I made it 2010. Sorry for the mistake. Sufezen is a rosuvastatin with ezetimibe, so I took it on combination therapy, but I missed because I made 20 to 10 because she was not on LDL level, so it's a typo, I'm sorry. So we optimized the diuretic dose, thank you for emphasizing. And of course I had already with her the discussion on a renal denervation, but she preferred to first try with a different medication scheme, and that's also why I convinced her to at least try with lercanidipine. And then we again have a 24-hour blood pressure measurement where she comes back with this impressive, that's also why I brought them along, these impressive similar results on 24 on day and on nighttime blood pressure. And this is also with an observed medication intake that she comes back with this. So I think...
Okay, it's voting time again. So she's a non-dipper. Right, an adverse prognostic finding. Her blood pressure isn't going down at night. She's on so many pills, I can't quite remember them all. You know, the yield when you go from 5, 6 to 7, 8 is pretty low. So Atol, Felix, what do you recommend now?
I will call Felix.
Well, I mean, on multiple medications not reaching target, if she's interested, so patient preference comes into play. If she's interested, I would offer her a renal denervation procedure.
Hands up in the audience for referring this patient for renal denervation. Hands up for try something else. I don't think there's anything left. Really.
No, there is nothing left. She's taking 5 pills in the most appropriate dose. Remember that she had only 60 of heart rate, so there's no way we can increase the beta blocker any further. We can increase aldactone, I agree, but remember she had already a kalium of a potassium of 4.2 on the first blood test, so we checked it, but
We've just got 1 minute left, so
yeah, okay.
we're dying to see the result
she
of this.
comes back. Renal denervation. Long story short, wow. I have this impressive result. That's also why I brought it. And this is also after after 1 month, as I said. I have another patient who took other patients who take really long to respond or even don't respond to renal denervation. But she came back with all the medication that she's taking. Yeah. Yeah, and that's also why I took it along, because then my question was, what would we do? But we have only 30 seconds left.
Yeah. But you did directly observe therapy before and after.
Yeah,
so
that's
you
what we
fed
always
the
do.
patient their tablets.
Yeah.
And it was 140 odd, and then you fed the patient their tablets, and it was 107.
Yeah.
So the denervation is the difference.
Yeah, the denervation is the difference. It's an impressive result. Like,
you know, sleep apnea.
Though she's still not having a dipping pattern. Eh?
No, yeah. I also saw. And the CPAP is working correctly, but she's obese, very obese.
Excuse me, for how long we wait between optimization of drugs and
Good question. Because she did not have symptoms, I sent her home for now, and she's in the cardiac rehabilitation now. So we observe her regularly. We have blood pressure measurements regularly, and I planned a 24-hour blood pressure measurement again in 6 weeks after seeing her, and then we can discuss eventually to cut back on 6 weeks, because she reacted so well to the treatment. Otherwise, I would leave 3 months between, but. This is because she was a quick responder.
Thank you, Sophie. Thank you very much. So just a couple of words, closing remarks. First, I would like to thank all the speakers for the quality of their presentation. Well, to summarize, I think what we have learned during this 60 minutes is first, the latest clinical evidence regarding renal denervation performed with the ultrasound device. I think we've been through the clinical evidence covering a wide range of patients and showing that the therapy works. Then I think Felix showed us the practical part, how to finally use the device, and also what are the information required to perform a safe and efficacious procedure. I think Sophie illustrated nicely, finally covering the assessment of the patient, the pharmacotherapy, and then the option of treating or not with renal denervation. And I think the discussion was very interesting, involving the audience online and on site. So I would like to thank all of you for this nice afternoon and wishing you a very nice meeting. Good afternoon.